But paradoxically, heterozygosity for factor V Leiden or prothrombin don't substantially increase the recurrence risk. And there's even data that people with more severe thrombophilias, like homozygotes with factor V Leiden or compound heterozygotes for V Leiden prothrombin, who have anywhere from a 20 to an 80-fold risk for a first event, may not even have a higher risk of recurrent events. That's one paper that suggests that might not be the case, a retrospective study. I think we need more data on that point, and I think operationally, I don't see a problem in worrying more about recurrence risk in people who have these dual thrombophilias. I might say that antithrombin protein C, protein S, clearly there are some families that have a very strong penetrance of thrombosis from the old literature. The case that was presented today was unusually strong penetrance for an isolated prothrombin mutation in my experience. But I must say, if you look hard, you will find people where they're the only individual in their family that they have protein C deficiency or protein S or even antithrombin. And I think whether they should be regarded as being as high risk as a very penetrant family, I frankly don't think, and as we've already heard, family history I think is important to keep in mind in terms of thinking about an individual patient. So I think family history is key too. But all of this has led the ACCP to say that the presence of hereditary thrombophilia has not been used as a major factor to guide duration of anticoagulation because the evidence from prospective studies really suggests that these are not major determinants of the risk of recurrence. The major determinant is provoked versus unprovoked. So this has led to a lot of discussion and controversy over who should be tested. From nobody, and if you'd invited Fritz Rosendahl here, who has done a lot of the research, he would probably be on the nobody list. I don't know whether he still speaks so strongly. It's somewhat apolitic, but anyway, he's made some pretty strong statements in that regard. I think, I must say, I have gotten more and more cautious, but I think if there's a strong family history in first-degree relatives with events less than the age of 50, I think those are the people you want to target. I think there are many other patients there, younger patients with venous thromboembolism with no other risk factors, and you can always go to the left. Any patient with VT, clearly some of these practices, I think, raise more questions than answers. And, I put up here the kind of conversations I have with patients before I do testing. Sometimes patients want to know, and oftentimes physicians are curious. I don't think that's a very good reason, but if patients really want to know what their risk factors are, I think it's certainly reasonable to discuss it with them. There is the issue of identifying family members who might take preventative measures, but there are a lot of negatives up there. The cons, I tell patients what we learned by doing primary thrombophilia testing is really probably not going to influence their management. I think the issue of testing family members, particularly for some of the common thrombophilias, factor V Leiden and prothrombin, opens up a whole can of worms, particularly around issues related to contraception, because even if they do carry factor V Leiden and prothrombin, and one first-degree relative has a clot, they still have a fairly low risk of having an event. But we generally, if you're going to test somebody, you really then should use the information, and I think in the best way we know, and give patients options to really minimize their risk. And there are obviously other hormonal approaches than oral contraceptives now. We have IUDs with progesterone, which can be used in women who've never been pregnant, and progesterone-only pills. There are safer methods, I believe. There are issues of over-aggressively managing people if they have thrombophilia, and then, of course, all the testing and consultations and undue anxiety that be created. So is there anything to help us out in figuring out what the risk of recurrence is in the idiopathic group? And I'll speak a little bit about D-dimer, gender. I think there's been issues about people with DVTs, about residual thrombus and ultrasound. The Italians have published on residual thrombus, which can occur in about 25% of patients with a single DVT, as being a potential marker for recurrence, but other groups really have not found it to be independent. And I think the major place I use it in my practice is to establish a baseline at the end of therapy, so I know, particularly if the patient's coming off anticoagulation, that I can diagnose a recurrence, knowing what their leg looks like when they've completed therapy. And then we've heard a lot about these clinical prediction models, the Vienna models, the HER2 models, the DASH models. They all involve D-dimer. The data is quite interesting. None of them, though, have been prospectively validated, arguably not yet ready for prime time. So let's talk a little bit more about D-dimer. This was the study of Palaretti in 2006. This was the first prospective trial using D-dimer to try to risk stratify people after unprovoked DVT or PE. They had to have had at least 3 months of vitamin K antagonist therapy. They measured a D-dimer 1 month after stopping the vitamin K antagonist. And then they had a randomization based on the D-dimer results. They used a point-of-care D-dimer assay, the simplified D-dimer, where the cutoff is probably 500. And so the normal D-dimer group, 1 month after stopped anticoagulants. The abnormal ones who were elevated were randomized to either stop anticoagulants or continue. So the continuing anticoagulants obviously had a low risk of recurrence. So let's just look at the two groups with the abnormal D-dimer that stopped anticoagulants and the normal D-dimer. And you can see that the normal D-dimer had a 4.4% recurrence rate in that first year, whereas the abnormal was 10.9%. So there was some dichotomy here of about 2.5-fold risk in terms of using a single D-dimer measurement after anticoagulation is discontinued. And when they did a post hoc analysis looking at sex and age, you can see that the D-dimer really appears to work best in women less than 65 who had a 0.4% recurrence rate if their D-dimer was low, whereas the males all were over 5%, and clearly the older patients in his study at least had a higher recurrence rate. So seemingly by the post-hoc analysis, less useful perhaps in males and females, although potentially useful overall because of a less than a 5%. So Clive Kieran, based on the Palaretti, mounted a large cohort study that we actually had the opportunity with many centers to participate in, and that's now in press in the annals, really to use D-dimer. Again, the same assay, the simplified D-dimer. The advantage is you could send it to all sites and have them all using the same D-dimer assay, the point-of-care assay, to select patients with the first unprovoked VTE who have anticoagulants stopped after 3 to 7 months. And we enrolled 410 patients, mean age of 51. 319 patients had a D-dimer that was low both on vitamin K antagonists, because if it's high on vitamin K, you know it's going to be high off. So only if it was negative when they finished warfarin and then checked them 4 weeks later. They had 319 such patients. You can see that the entire cohort, though, had a higher risk of recurrence in the first year, 6.6%, and the men were about 9.7%, but the women were substantially lower at 5.4%. And we did include women on estrogens in the study too. There was some question whether they should be regarded as provoked or unprovoked. Palaretti included them. None of those women, 58, had recurrences. So again, it appears here that the D-dimer risk stratification will be most useful in women, less useful in men. Now, that's not to say men with a high D-dimer might not have an 18% recurrence rate in this study, but it doesn't identify that group that gets down around 5%. So if you use D-dimer, you must use an assay that's been studied. It's only validated really with a first unprovoked VTE, not in other groups. I frequently have my fellows wanting to test it in other patients. I say, well, just beware, we don't have the outcome data to base decisions here or algorithms, and again, most useful in women probably under 75. All men have a higher recurrence rate, greater than 10%, about 10%. I'd like to say guys are losers. What about aspirin? Aspirin was shown in 2 studies last year or 2 years ago to have some modest activity. I think it's an interesting insight because it's long been viewed that aspirin's benefits are really on the arterial side, but I think you have to believe based on these studies that there is a modest, perhaps 30% risk of recurrence reduction with aspirin, but I don't think it really enters into real consideration for people you're really worried about